Today, I am going to present the cardiovascular risk and legal restrictions of Alvimopan. Before I get started, I first want to thank my content expert, Nick Parker, for his support and guidance on this topic. The purpose of this presentation is to briefly go over the mechanism of action, therapeutic use and drug efficacy, and dose regimen of Alvimopan. Also, I am going to further discuss the evidence of the cardiovascular risk related to its use and explain the REMS program and PNT restrictions here at UW Health. Alvimopan is also known as Interget. It is a competitive antagonist that can bind to the GI mu opioid receptors without alternating the anesthetic effect of opioid. Morphine and other mu opioid receptor agonists are commonly used for the treatments of acute post-surgical pain, but they may not also known they're also known for their inhibitory effect on the GI motility and may also prolong the duration of post-operative ileus. So Alvimopan can help to accelerate the time to upper and lower GI recovery after surgery among patients undergoing various surgeries such as the small bowel resections, primary anastomosis, and radical cystectomy with urinary diversion. In terms of its efficacy, there is a systematic review done back in 2020 that reviewed the Alvimopan treatments with post-operative outcomes using the qualitative synthesis of evidence. There were 9 randomized controlled trials and 35 non-randomized studies included in this study to assess the impact of Alvimopan on length of stay as its primary outcome. So here is a table that I made to summarize the results in this study. Overall, for bowel resection, of the 31 study assessing the impact of Alvimopan on length of stay, 23 of them favored Alvimopan, and 8 studies did not favor the use of Alvimopan. Overall, the evidence are considered as low to moderate certainty using the grade approach. For the next row, the radical cystectomy, there were 7 studies that favored Alvimopan with low certainty of evidence. For other off-label use, such as total abdominal hysterectomy and retroperitoneal lymph node dissection, the study concluded as limited evidence supporting its use for surgery. There is a similar effect observed in both traditional and enhanced recovery pathway setting. But as you may know, the enhanced recovery pathway elements vary across different studies. They can be used different early oral intake and the different multi-module or the opioid sharing analgesia like acetaminophen, ibuprofen, and a tab block. There is a low certainty of evidence supporting Alvimopan for patients undergoing the minimally invasive surgery. There is also a low certainty of evidence supporting that this medication reduced the healthcare costs in the context of the traditional care with open surgery. The cost saving varies, range between 200 to 3,000 US dollars per patient. So I found some limitation of this study is that the meta-analysis was precluded. The investigators stated that there is like a high prevalence of study at critical risk of bias. So the inclusion of these studies in meta-analysis was not recommended since most of them are non-randomized studies. There is also a heterogeneity in outcome reporting. Some trials reported as hazardous ratio versus some other reported as mean difference for the length of stay. So it's very difficult to combine the results to produce like a single pool effect estimation. Back in 2018, there was a medication use evaluation done at UW Health that retrospectively reviewed the use of Alvimopan for radical cystectomy from October 2015 to August 2018. So back then, Alvimopan was restricted for the radical cystectomy use, and the attending surgeons must be an urologic oncologist. And the intervention group include patients who received at least one dose of Alvimopan during admission from November 2017. So that time was the time when the Alvimopan was first introduced and used at UW to August 2018. The control group is patients that did not use Alvimopan during the admissions, and the data just used like the working back in time from the August 2018. So here is the baseline characteristic of the data collected in the MUE. The Alvimopan group has 35 patients and the control has 40. I noted that the control group has significantly post-operative TPN use, and discharge to SNF rate is much higher compared to the Alvimopan group. So I believe the control group patients was definitely were more like sicker and also need a greater care compared to the intervention group. So to summarize, the finding is that in the setting of the radical cystectomy at UW, there is a significant reduction of recurrence of post-operative ileus in a Vimopan group compared to the control group, with 5.7% versus 32.5%. The length of stay also decreased significantly in the Alvimopan group when compared to the control group, with 7 versus 10.5 days of stay difference. There was no adverse effect noted from using the Alvimopan in this MUE. And the final report concluded that based on this study and also other published data, Alvimopan may also provide benefit in other significant abdominal surgeries. So now going back to talk about some pharmacokinetics of this medication. The metabolism works by allowing the gut microflora to hydrolyze itself to an amide hydrolysis compound. So that hydrolysis compound serves as an active metabolite. The bioavailability is about 6%. Half-life elimination is 10 to 17 hours. And time to peak in plasma with parent drug is 2 hours, and with the metabolite 36 hours. Biliary excretion is considered as the primary pathway of the drug elimination process. The unabsorbed drug and unchanged drug result from the biliary excretion were then hydrolyzed into its metabolite by the gut microflora. And then the metabolite was then eliminated in the feces and also in urine as an unchanged metabolite, and also some other metabolite as well. As for drug interactions, it interacts with the opioid antagonist, as it is itself, it's an opioid antagonist. So some medication that it interacts with are the methylnitrazone, the nidalmedine, and nioxygel. The interaction increases its adverse effects and also increases the risk of the opioid withdrawal. It also interacts with the opioid agonist, which can potentially increase its own adverse effect. So it's known that this medication is contraindicated in patients receiving the opioid for more than 7 days prior to surgery. The reason is that patients with recent exposure to opioid are expected to be more sensitive to the effect of the mu opioid receptor antagonist. So it may cause more GI adverse reactions, such as like stomach upset, nausea, vomiting, and diarrhea. Some common adverse reactions are hypokalemia, dyspepsia, urinary retention, anemia, and back pain. Myocardial infarction is the black box warning for this medication, which I am going to spend some time to talk about next. Previously, there was a 12-month study done of patients treated with opioid for chronic pain. The incidence of MI was significantly higher in patients treated with Alvimopan 0.5 milligram twice daily compared to placebo. The MI events occur between 1 to 4 months after the treatment initiations. However, the study found there was no other observed MI risk in the short-term treatments, and there is no causal relationship established with the medication. Therefore, FDA initiated the Alvimopan REMS program with a goal to reduce the potential risk of MI by ensuring this medication will only be used in a short term and in a hospital inpatient setting. So here are some requirements for this program that first, the medication can only be dispensed by inpatient pharmacies and hospital that perform the bowel resection surgery and also enrolled in the program. There shouldn't be any outpatient use or transfer use to any unenrolled hospital pharmacy. And we should also make sure to report any adverse events to the program. Lastly, as for its dosing, it is a 12 milligram by mouth 30 minutes to 5 hours prior to surgery, followed by 12 milligram twice daily starting the day after surgery until discharge. The duration is the maximum of 7 days of 15 doses. It is not recommended for a patient with severe renal impairment and severe hepatic impairment. In summary, so at UW, the PNT formulary restriction is to use Alvimopan for surgery that includes bioresection with primary anastomosis and or planned primary anastomosis or any urology surgeries. The prescriber must attest to Alvimopan education prior to ordering, and use must not exceed 15 doses. Here are my references.